Among this sea of expert arthroscopy surgeons, I think I'm a little odd man out. This is my disclaimer. I use 3 robots for a uni. We are all been dignified carpenters, and we've been blamed or been decorated with this name for many years. So we started getting this tibia from the lateral side, then medial side, then even if the ACL is not there, even we cut. And recently we have seen so many of them cutting this fibula as well. We are not sure whether that regenerates cartilage or not. That's a different issue. However, some of us have started doing this beautiful metal piece. Rather than a carpenter, we started becoming a mason, I think. We started putting metal and cement in this situation. However, you see, we should all agree that, as he said, we are knee surgeons, and both have their pros and cons, and they had a satisfactory result in the past. But which one is the best for the current patient, what has just been presented to us, who is a 60-year-old lady? I will not tell it anything for the debate. I just describe everything what is there in the literature and what is the evidence in terms of the outcomes, complications, rehabilitation. You tell any one of these single points, we will discuss on them. What is happening to the UKA in the world? You can see this in the last 10 years, in the last 10 decades. The number of UKA done in America was 100,000 cases. See how many HTOs were done in this study. That was just mere 2,183 cases. You can imagine that there must be a strong reason why people started doing more and more HKAs. Second one is about the cost effectiveness. This is a very important thing. It is not just the mere cost. It is the implant cost, etc., etc. This is a Canadian study. We have studies from all over the world. You can see this. We have a highest cost effectiveness. For example, the revision, the functional outcome, etc., etc., which has all been modeled into a statistical model. The highest is for UKA, followed by TKA, and then by high tibial osteotomy. What about the patient-reported outcomes? Controversies. However, you can see in a lot of these recent meta-analyses, there are some older ones, there are a lot of them newer ones. We have better pain control. We also have better VAS score, functional score, as well as the better high forgotten joint score with the UKA compared to the high tibial osteotomy. We all agree with this point. There is no controversy. Fractures or the osteotomies, they take time to heal, and we need longer rehabilitation, and also the pain in the post-operative period. Complication, almost uniformly it's been agreed all over. Compared to high tibial osteotomy, UKA has been demonstrated fewer complications, infection, leg length discrepancy, DVT, peroneal palsy, less post-operative pain, lower revision rate. All of them are in favor of a UKI. This is the most important thing for any patient, especially in a country like ours. How many years you are going to give this patient a good knee? Is this going to be for 10 years, 15 years? Fortunately, the arthroplasty surgeons have started thinking now the UKA is not a stopgap mechanism. It can even last for their lifetime. For example, there are studies which suggest the 90% survival in 20 years. And for the HTO, it is only a 44% in the literature. Revision to TKA, both of them are a little difficult, both have variable result. I think they may be comparable. There is no consensus on that. However, you see one of these which I have recently revised, it is just adding a stem and an augment, nothing difficult. However, you see if an high tibial osteotomy is done in this way, a severe osteoarthritis, the valgus, the reverse slope, getting all of them has given me a publication, but it is difficult. You can see that everything in the armamentarium has to be used. So this is the main point. Returning to the sports has been the main thing about HTO. But however, you can see nowadays, these patients which have been done HTO, you see that if there is a little cartilage only, you can do HTO. These people are younger, physically active, and these patients who have partial knee replacement, their surgeons will tell them, don't do much activity, your poly will get worn out. So is it induced by the patient or is it by their surgeons is a debate. However, because of the new poly, the returning to sports has been shown nowadays in a lot of these studies are in fact better than HTO. See these studies, several studies. See the red in the middle, 80 to 90%, up to 100% of patients have gone back to the higher level sports, including the soccer and everything. This is another surprising thing in the literature. The guys who have done more sports, more active, their partial knees lasted longer. Maybe the quality of the bone. But so using the unicondylar knee is not going to decrease their survival. Finally, technically demanding operation, it used to be very difficult and experience linked, and the outcome was a link to the surgeon experience, etc. But nowadays, the robotics have made it easier. The precision is there every day in every X-ray. When you have a robo, you can see that. Some of you might have experienced that whatever has happened to the patient, the X-ray is good every day. This is one of my eye-opener case. This is done locally. Bilateral high tibial osteotomy. Patient wasn't happy even a day. She is a 55-year-old. She came, begged, and got one knee. Now she is begging to get the another knee every other week coming to the OPD. This is another eye-opener. One side, because of the contraindications, I did a total, and on other side, the partial on the same day. This patient is extremely, extremely happy with the partial compared to her total knee. To conclude, UKA has superior patient-reported outcome, lesser complications, shorter rehabilitation and lesser pain, longer survival, better cost effectiveness. The world is doing more and more of UKAs exponentially, and the sports and activity level has been shown to be equal in the recent literature. And the robotics have made it easy and improved the precision. And hence, even though we can take the literature to support us, rather than eliminate ourselves like a drunk holding the lamppost, I think it's important that we respect the literature and the evidence, and hence my good friend Chirag's case should have a partial knee. Thank you.